Hey everyone, Dr. G here. Welcome back to Discussions with Dr. G. Congrats on being one of the cool kids who actually cares how public health really works and not just memorizing stuff for the NCLEX. So let's zoom out for a second. Big picture. The whole goal of public health is getting people as healthy as possible wherever life is actually happening. You know, where people live, learn, work, and play. That's not just straight from a textbook. That's Healthy People 2030's whole thing. If you're an overachiever, write that down because it pops up everywhere. Now, we throw the word vulnerable around a lot in nursing, but what does it even really mean? It's not about blaming a person, right? Vulnerability is about being at higher risk of poor health, crappy outcomes, and mainly because resources are limited. And these aren't just individual problems. They're tied into bigger stuff. The kind of neighborhood you can afford to live in, the quality of your school, whether the air is clean or your landlord fixes the heat. There's this real mix of personal and environmental and social factors all tangled up together, what we call the social determinants of health. SDOH for short, because we love an acronym. Education, housing, food insecurity. Those are the drivers. I mean, if you can't afford your meds or you don't have running water, it doesn't matter how many lectures you watch about hypertension, right? I always come back to this one patient, my first time on the floor. She kept coming back with heart failure exacerbations, and the docs would do their thing, but nothing changed. Then I found out by actually asking that she was couch surfing. No fridge for her meds, and her salt intake out of control because she was living off of cup of noodles. Makes you want to throw the discharge instructions out the window because if you can't address housing, you're just doing patient ping pong. The social determinants piece isn't a side note. It's the heart of the work if we want, to actually eliminate disparities and give everyone a fair shot at being healthy. So let's get into specifics. Who's most at risk? You can probably guess. We're talking about Black people, Indigenous people, people of color, or BIPOC individuals for short. Folks dealing with systemic racism and chronic stress, which, heads up, is a real thing. Higher rates of diabetes, heart disease, the works. Then you've got families living paycheck to paycheck, uninsured or bouncing from place to place. LGBTQIA plus youth and adults. Ridiculous barriers to care from stigma, and let's be real, some providers who don't even try to ask about their pronouns. Veterans dealing with PTSD, substance use, complex chronic stuff. Toss in refugees, undocumented folks, people with serious mental illness or substance use issues. It's a long list, right? But wait, we're not done. There are also people who've been involved with the justice system. These clients tend to have way higher rates of mental illness, chronic stuff like diabetes, maybe a disability, exposure to violence. Oh, and let's not ignore the breathtaking lack of access to decent health care. Let me throw in children and adolescents, pregnant teens included, who get tossed a healthy serving of ACEs. That's adverse childhood experiences. And lifelong health risks get baked in early. Older adults trying to juggle a dozen meds, medical bills, and being a caregiver themselves. Then you have the sandwich generation, caring for aging parents and their own kids, folks with disabilities, mental illness, or substance use disorders. You see how quickly these groups start overlapping, right? It is messy. There's a real challenge here. As nurses, we're supposed to balance our own safety and the rules of the setting, but still show up for people with respect and dignity. Our role is actually pretty clear. Assess, advocate, connect, repeat. It's easy to let bias sneak in, even unintentional. But our legal and ethical duty is to treat everyone like a human. They're entitled to health care. That's not up for debate. Let's take a slightly closer look at some of these vulnerable populations. How about people living with substance use disorders? Well, it's wild. About 10.5% of folks 12 and older in the US have an alcohol use disorder each year. That's millions. Complications run from withdrawal to stigma, and the shame is sometimes worse than the physical effects. Something I like to hammer into my students is stop calling clients addicts or abusers. Use non-stigmatizing language. If you can, use tools like SBIRT. That's screening, brief intervention, and referral to treatment. To keep the focus on support and solutions versus judgment. Everyone deserves care, diagnosis or not. Now, poverty and houselessness. Nearly 38 million Americans living below the poverty line, and about 1.5 million experiencing houselessness each year. Chronic illness, higher infant mortality, shorter lives, whole 9 yards. There was this patient, let's call her Maria, living on and off the street, dealing with diabetes and all the complications. What turned things around for her wasn't just a prescription, it was access to wraparound services. The community health nurse coordinated food, shelter, medical care, all the basics, before she even started tackling the glucose. And that's how you do holistic, client-centered work. Now, we can't leave out mental health. Half of all Americans will have a mental disorder at some point, and only half of them will get the care that they need. Stigma and lack of resources are huge issues. So what works? Building trust, using therapeutic communication, screening at-risk groups, giving ongoing support. It's all about primary, secondary, and tertiary prevention. Prevent, catch early, and help manage for the long run. And then there are clients with disabilities or chronic illness. This is everything from people needing a wheelchair ramp to complex neurodifferences to invisible illnesses that cost a fortune to treat. As nurses, the focus has to be on each client's strengths and unique factors, not just the chart diagnosis. And honestly, don't forget about the family and the team. You can't provide comprehensive care by yourself. So let's not forget rural communities too. About 46 million Americans live in a rural community. They're dealing with higher rates of COPD, hypertension, cancers, maternal and infant issues, you name it. The biggest barrier? You guessed it, distance and lack of providers. Telehealth is changing the game a bit, but advocacy for screenings and basic services is always needed. Migrant and urban populations have their own challenges too. Migrant folks deal with injuries, infections, poverty, no health insurance. Plus, they're usually moving around a lot. Nurses can provide culturally sensitive care and link people with mobile clinics, vaccinations, and occupational support. In cities, there's hazards from pollution to policy, failures to social discrimination. That means partnering with agencies and showing up for health programs, not just one-on-one care. Finally, our underrepresented groups that face race, gender, and other discrimination. Structural racism and bias are alive and well, and you see health inequities playing out in real time. Nursing here is about more than care. It's about advocacy for social justice, breaking down really stubborn stereotypes, and pushing for inclusive policies. Okay, I know that was a lot, but each of these groups faces unique risks, and our response has to be tailored. So let's look at how we actually put this knowledge into action using the nursing process. So the clinical skills that actually move the needle, okay? Rapid screening for SDOH. Don't be shy about straight up asking, hey, are you worried about housing, food, or how you're going to get to your appointments? If you're feeling fancy, use these tools in the chart. But honestly, a checklist on a sticky note works too. Then you've got to screen for risks. ACEs, mental health, substance use, intimate partner violence, all the stuff we wish was rare. Whatever the risk, flag it, and then make a plan. Trauma-informed and culturally competent care they're not just buzzwords, guys. You need to ask, not assume. Use people's names and their pronouns. Get an interpreter if someone needs one. Remember, so many folks come to clinics having been burned before, and it's real. And if you don't make it safe, they're not going to come back. Let me give you a quick example here. We had this young LGBTQIA plus patient who was new in town, kept missing follow-ups. The chart is full of non-compliant. But when I actually asked how things were going, he told me his last provider laughed his pronouns. I'm like, really? So I used trauma-informed language and said, whatever you want to share is fine. This is a judgment-free zone. And I sent him home with info on local safe clinics and a support group. Next appointment, he shows up early and brings a friend. Sometimes a little respect and good information does more than any prescription possibly could. And let's not sleep on the teach-back technique, okay? Ask your patient to repeat plans in their own words. If they can't, explain it to them again. If they aren't going to do it, they aren't going to do it. But at least you know that they understand how to do it. Make resources clear, simple, in their language. Stick with the basics. Can they name their meds? Do they know where to go for help? That'll save you so many panicked phone calls. So make health literacy a priority. Plain language, teach back, confirm they get it. Simple. Don't assume people read at a college level either. Heck, I barely remember my undergrad reading assignments, and I teach this stuff. Be proactive about referrals. Know your Medicaid office, your food banks, housing resources, SBAR for handoffs. Always get consent, and follow-up is non-negotiable, especially with folks who get lost in the system. If you ignore prevention, you're just stomping out fires. So focus on chronic disease injury prevention and adapt your plan A to whatever community you're in. Trust me, there will be a plan B, plan C, and probably even a plan D by the time you're done. Okay, so you've got the skills down. But how do you make it all work? Especially on a busy day with a line out your clinic door. Start with coordinating care. Know your resources. Medicaid, food banks, community clinics, all of it. If you don't know what's out there, make friends with your social worker stat. Use good old SBAR for handoffs, situation, background assessment recommendation, and document, especially their SDOH and referrals. Does it sound like a lot of paperwork? Yeah, it does. But if it's not in the chart, it didn't happen. Get those consent forms signed before you share info. And you also better be up on mandatory reporting. Child abuse, elder abuse, certain diseases. You don't want to miss that, trust me. You don't have to have evidence of or proof. You merely have to have a suspicion of abuse. Now, here's the real magic. Shared decision making, okay? You're not supposed to hand down orders on from high. Instead, work with your patient, define the problem, list the options, weigh the pros and the cons, figure out what matters most to them, and then decide together on how to move forward. Maybe let's say you're working with an overwhelmed caregiver for an older adult. Picture someone who barely has the time to shower, let alone navigate Medicare, okay? I spent a lot of time connecting one exhausted daughter to a local respite program. The guilt she carried was crazy insane. But once she got a break and support group referrals, the whole dynamic between her and the person she was caring for changed. That is advocacy, guys. That is community nursing. Health literacy is non-negotiable, so always explain things at an accessible level. Teach back, again, not just a buzzword. It actually works. And only provide written stuff in the patient's primary language. Giving someone English-only instructions when they speak Spanish at home is kind of futile. That's a fast track to confusion and honestly, unsafe care. So let's talk care coordination real quick. Find your local resources and actually use them, okay? SBAR for your referrals, getting consent, hello HIPAA, and then double check the referral went through, because that's another barrier. We'll send referrals sometimes and the other side never gets them. Prevention matters. Vaccines, screenings, chronic disease management, all of it. And advocacy, whether it's paperwork, affordable meds, or calling out the system when it fails your patient. That's in the ANA Code of Ethics. You're allowed, even expected, to be a squeaky wheel for your patients. Documentation? My kingdom for a good note. Document SDOH, risks, referrals, teach back results, and always confirm consent. Know your mandatory reporting laws for abuse and communicable diseases. End of life planning? Do it respectfully and actually honor the patient's choices, because that is also equity. So, my quick checklist for any new grads out there, stuff I really wish someone had told me before I stumbled through my first couple months. Screen SDOH and ACEs. Use TeachBack. Have resources in a patient's language. Document everything. Follow up. Approach care in a trauma-informed way. And check your bias at the door, because we all have them. Don't forget about your caregivers. And if you can, jump into quality improvement projects to close gaps like vaccine clinics or screenings. And when it comes to decision making, don't forget to share the decision making process. Patients know their lives better than we do. Your job is to offer options, lay out pros and cons, clarify their values, and then build a plan together. Last thing, respect advance directives and patient wishes. Keep your ethics tight and always look for a way to close those gaps. Whether it's calling in a translator, reminding a family about FMLA, or flagging that a patient missed their mammogram. Every little bit adds up, okay? And remember, vulnerability isn't about skill, it's about barriers. Our job is to spot them, name them, and do something about them, one person at a time. So, let's wrap this up. How do we as nurses make a difference in the community? It starts with assessment. If you've ever done a windshield survey, basically rolling or walking through a neighborhood and taking notes on what you see, you'll know it's low budget, but pretty eye-opening. You notice things like food deserts, closed clinics, even just cracked sidewalks that could mean potential trouble for mobility. Then comes diagnosis and planning. We're identifying what's really going on. Are diabetes rates high? Is there unaddressed mental health stigma? We prioritize the needs and work with all the stakeholders, maybe parents or school boards, whoever will actually show up at the meeting with a cup of cold coffee, okay? Implementation is where the magic happens. We deliver interventions that are population focused, whether it's a vaccination campaign at a community center or a mobile clinic in a farm field. The interventions need to be culturally competent, always. Otherwise, you're just spinning your wheels. And we can't forget evaluation. If something isn't working, we just don't throw our hands up and walk away. We tweak it, we adjust it, we stay open to new data. Nursing is one of those jobs where you never really reach the finish line, in case you guys hadn't figured that out yet. What pulls it all together is our advocacy work, partnering with community organizations, writing letters to policymakers, collaborating with food banks or schools. We're constantly applying primary, secondary, and tertiary prevention, education, early screening, ongoing management. In my classroom, I once asked students to role play care planning for incarcerated clients. The discomfort was real, and then someone said, "Why are we talking about them like they're a different species?" It was one of those teaching moments that made me realize just how ingrained our biases can be, and also how hopeful I am about the next wave of our nurses. So yeah, being a community health nurse means being a fierce advocate, a collaborator, and a pretty creative problem solver. If this all sounds like a lot, that's because it is, but you're not alone. Stick around for our next episode because we're just getting started tackling violence and trauma in at-risk populations. This is Dr. G, signing off for now. Take care of yourselves and, of course, your communities. Until next time.